Some of us think of the 80s as the decade of health. Health clubs, health sports drinks, Nike shoes. We aerobicized and power walked and consumed fiber until it stressed our marriages. And yet we still died. Jackie Kennedy, Arthur Ashe, Jim Fixx. The old and the young among us still succumb to aging, to death, to disease processes. So ushered in the 1990s, some think of it as the decade of death, where our banner headlines on our morning paper talk about physician-assisted suicide. Who is vying for that heart-lung transplant? Who wants to disconnect that G-tube? Our fine literature in print includes such books as Final Exit and How We Die. We desperately seek to control a life experience. And physician-assisted suicide is, in a sense, a struggle, an attempt to control a life experience. You can't really see it. Some of us talk about dying with dignity. Actually, when I spoke to John about this conference, I don't tend to use that term. I talk about dying with integrity. That means to die with interpersonal relationships, our spirit relationship, our sense of self intact. Dying with dignity, in a sense, confers that there's a judgment, and quite frankly, many that I've spent time with, I wouldn't necessarily judge as being dignified, but they have died in the way that they live. And again, the struggle to control the process and to act with integrity up until the point of death. Next slide. Even in the 1960s, a phenomenal woman named Dame Cicely Saunders began to recognize the gross divergence between care for those with potentially curable illnesses and those who were labeled as dying. Even in the 60s, as medical technology took off, our ability to diagnose, to image, to intervene shot off like a rocket, our care for the dying patient lost ground. Next slide. We use such terms as treatment failure to describe folks who are no longer responsive to treatment or to therapies. Dying was no longer a diagnosis that would require hospitalization, and there was very little reimbursement if you happened to take a long time to die. In fact, the home care industry found itself unable to care for folks because they didn't have a skilled need, but rather they were simply dying. Saunders took this change and this movement to heart, and proactively, in 1967, she opened the doors of St. Christopher's Hospice in London, first inpatient hospice. Hospice was a specialized, organized care system devoted to the care of the dying patient. What was interesting, and what Saunders and her folks recognized quite quickly, Dame Saunders is a nurse who trained as a social worker and then trained as a physician. What they recognized is that there continued to be this dichotomy of care. There are hospice hospitals in England and there are acute care hospitals in England, and you go to one or the other depending on your goals of treatment or potential response to treatment. And the two for a long time didn't communicate very well. So Saunders and others created a discipline of medicine, a specialty called palliative medicine. And physicians became specialists in palliative medicine. And these docs could then communicate and begin to intermesh with the acute care system and ease the transition to hospice. Next slide. The greatest boon, I think, of palliative medicine has been the attention to symptom control. As Dame Saunders says, pain nails you to your body. Therefore, if you are to be able to live until you die and to process the death experience as part of the whole of your life, you must be free of symptoms. If you are to contemplate, to work with friends and family to bring closure, you cannot be so besieged by symptoms that your slightest movement or slightest breath brings you back into the physical realm. Probably one of the greatest things the Lord has given us is the ability to think beyond ourselves. And if we are constantly brought back to our frailty, our bodies, we can't do that. So Saunders and her peers developed palliative medicine, and palliative medicine has given us a great deal of the art and advancement in terms, especially the treatment of pain. Pain is a four-letter word, and probably it is the most feared of all the symptoms of illness. Truthfully, the number one fear of folks is not so much the fear of dying or cancer or public speaking, but actually the fear of losing control. And those who are ill, the fear that they have or speak up with the most is the fear of being in pain. Within the realm of palliative medicine, some wonderful science has come forth, particularly in our understanding of the physiology of pain. What we know now is that folks with chronic pain send the message of pain actually through a different pathway to their brain. Those folks who experience acute pain send it quickly through what's known as a lateral pathway, and folks who are experiencing chronic pain send it through the medial pathway into the limbic system. And the limbic system is where our moods and morale originate, our sex drive, our appetite, etc., which is why people with chronic uncontrolled pain exhibit depressive symptomatology. Next slide. What we've also come to understand through pain research is that there is no maximum dose of pain medication, that folks will, whatever they need is what they need to take, that they're not going to run out of strong medication to treat pain, and that they will not experience a lack of relief because there isn't enough medicine to take care of pain. One of the things that we do as palliative care docs when we get together is share, well, what's the highest amount of morphine that you've used recently, and try to top each other. And within the last 2 months, I can say that a 46-year-old woman at one of our local hospitals dying of metastatic colon cancer was on 1,000 milligrams of hydromorphone an hour, and that's equivalent to 5 grams of IV morphine an hour. She did achieve pain relief at that dose. She exhausted the entire supply of pain medication for both local hospitals with the Evanston system. Next slide. The other thing that Saunders and others have developed for us is a way to make pain medication appropriate for the setting. If once we achieve a diagnosis, we oftentimes label ourselves as patients. And what we hope to do in the process of living with an illness is remain a person. And it's hard to remain a person if you've got a dance partner attached to you all the time infusing medication. So medication in patch form or oral form has freed up a person again to focus on the aspects of life without the accoutrements of disease dangling around them. Probably the greatest benefit of palliative medicine and the science of that has been a greater understanding about strong opioid therapy and the myth of addiction. The fear of addiction is probably the number one reason that folks will not take strong medication for pain. The myth that is even transmitted across the pharmacy counter, now don't take too much of this, you'll get hooked on it. I can tell you with authority that for people who take pain medication for pain related to terminal illnesses or even chronic illnesses, less than 1% exhibit addictive behavior. In a study in 1980, 10,000 patients taking strong medication for pain, 4 patients displayed addictive behavior. There were several other studies in the early 80s that confirmed that data, and then in 1986, a very provocative study by Ross Portnoy and Kathy Foley at Sloan Kettering looking at non-malignant pain, lumbosacral back pain, 38 patients taking morphine. 2 showed addictive or substance abuse behavior, and both had a prior history of substance abuse. Patients who take strong medicine for pain will not become addicted, and that fear is unfortunately one of the things that prevents folks from achieving adequate symptom control. What we must understand, however, beyond the physiology, is that pain is not simply physiology. That pain is not simply the destruction of a tumor into a bone. It's not simply the rampages of disease. Go ahead. But pain instead is the experience of a human being. And Saunders has described for us something known as total pain. Even in the International Association for the Study of Pain's definition, we recognize that pain is not just the physical, but it is the sensory. It is a physical and emotional experience. And in order to treat both, we must attend to both concurrently. If we emphasize one over the other, we will not control pain, and we will certainly not touch the aspect of suffering. So total pain is the physical destruction, disfigurement of disease, the limitations of our physical body, and certainly the psychological aspects that go into play. Labor pain is the promise of a new beginning. Metastatic pain is the promise of advancing disease. So the feelings or the meanings associated with pain are as powerful as the physical stimulus. And certainly within the social domain, certainly in our healthcare system with its meager resources, as was mentioned, for chronic debilitating illnesses, a severe illness may mean financial destruction of a family. Many are uninsured. How can they obtain symptom relief? How can they obtain support in the face of such an illness? And then, very underaddressed in our secular healthcare world is the realm of spiritual suffering. What does the pain mean to that individual? I remember, and we'll digress with a little bit of a patient story of a gentleman who was on our oncology unit who had metastatic prostate cancer. And every day he went down for radiation therapy, and every day he complained to the young physicians in training that he was in pain. So when he said that word, they gave him morphine. Well, they about snowed him by continuing to give him pain medication. They called me up and they said, "Now you told us that somebody wouldn't stop breathing if we gave them adequate pain medication when they were in pain, and this guy's almost comatose." So I went up to see the gentleman. After a good long conversation, it came forth that this man had been a Russian immigrant, had escaped the Holocaust, and there was a significant language barrier. He also didn't understand quite what it was that they were doing every day with that machine, and he was afraid. And for him, the best way to communicate his fear was to say, "I'm in pain." In a sense, it was a form of pain. He was frightened. Morphine does not treat that kind of pain. Education and companionship, and maybe some mild drugs for anxiety, can be much more effective. Next slide. Hospice is uniquely capable of treating total pain. The realm of hospice is tailored to address all the needs of patients and families as they deal with a life experience. It is a much better choice than physician-assisted suicide. Our present healthcare system is based on a physician directing care. It's somewhat of a hierarchy. Hopefully that physician will have a nurse by his or her side and really be a team in approaching patients, because this gives so much of a greater perspective and care plan to patient care. But hospice is actually a team approach to a patient. In reestablishing control for a patient, we ask the patient to direct their care, to determine what their goals are for therapy. And surrounding that patient as far as assessment and delivery of care is a team with various areas of expertise. The doc is no longer the top of the totem pole, but is one more team member. And that team consists of physicians, nurses, social workers, chaplains, aides, and other supportive staff. With their varying levels of expertise and ability to assess, they then form, with the patient's guidance, the plan of care. The team provides a more complete assessment and a more complete plan of care if you think about the experience of total pain. The team approach, again, is a circle. This slide to me doesn't get the message across because it lists it almost as a hierarchy. To be a hospice physician is a bit of a challenge to docs nowadays, because it really means to not consider yourself more important or more in charge than the chaplain. Go ahead. Hospice relies on nursing, and I'll tell you, to be a hospice nurse is probably one of the toughest, most demanding jobs around. You have to have a big vision as you approach a patient's bedside with a remarkable attention to detail. You have to be the Lone Ranger and yet a team player. It's critical that the nursing care of hospice, particularly since it's more often delivered in the home, is expert, because the assessment and communication to the rest of the team may oftentimes be via telephone, particularly to the doctor. The attention to detail, again, affirms for a patient that you are worthy, you are important, your slightest need is part of your plan of care. Involving the attending physician is critical. A good doctor is worth 10 milligrams of morphine, simply by presence. And also, what is important in involving the attending physician, next slide, is the fact that many of these physicians have long-term relationships with their patients who are now dying. And if they send their folks off to hospice, never to see them again, they have their own grief and loss issues that must be dealt with. So physicians must become a part of the team, not just to direct the plan of care, but to garner the support as they companion a patient through the process. Go ahead. Social work is also critical, and addressing sometimes those financial needs. Can I hire a caregiver? Who can be my caregiver? What's your church resources? What are your community resources? And certainly in the domain of, whoops, read that word. Go ahead. Of children. Go ahead, next slide. What we have come to understand is that children must be a part of the process. They must be involved in the dying process. A child that is excluded will perceive the event as punitive and will believe that the death of their parent or their grandparent is because they did something wrong. And they will live with that truth for them for the rest of their lives. And I'm sure there's probably folks in the audience who have had such conversations. I'll never forget a 52-year-old woman saying to me that when her father died at 6, she believed that she had killed him because she'd been naughty. And by being excluded from the funeral and from the process of his illness, that was reinforced for her. Children, even as young as 2, have death awareness and will process it. Their paintings, their drawings, their descriptions are amazing. Just watch Lion King with them. Hospice as a governmental agency is one of the few organizations that must have volunteer involvement. In order to be Medicare certified, you have to have the participation of volunteers. Volunteers are a very critical part of what we do, again, from a social aspect, to affirm for a patient who is ill that they are a person, that they have something to contribute, that a visit and just being with them is important. Another thing that's very important for many folks as they process their death in terms of the whole is biography therapy. Putting together a scrapbook of pictures or a tape recording or collecting letters to hand on to the next generation. And volunteers are often the people that make this possible. I've learned a lot from my father, who is a hospice volunteer. Learned a lot about the issues of being present and giving the person choices. Would you like to sit here? Would you like to read a book? Tell me about your life. These may seem trivial, but all these things reaffirm a sense of control and direction for patients, and also are part of pain control. Go ahead. Chaplaincy. Very, very important. We talk in hospice about companionship, coming alongside patients as they make the journey. I've companioned many folks through the process to death. It requires, of course, that one have a pretty intense sense of death awareness for yourself. Deep calls to deep, as the psalmist says. But it also requires that one be blank and open, I cannot come with my own agenda to the bedside. It's not my death. It's not my pain. Therefore, I have to come open-handed and with my spirit ready to respond to the needs of that person. This is critically important and also respects, again, the autonomy and I believe the movement of the spirit for that individual. Companionship and reinforcing that we are part of one another. I love what the last lecturer said about no one of us is really independent. Coming to terms with our relationships and finding closure and ability to leave with closure. Remember that families are those that survive the death, and they will walk with it. So a good death, the true meaning of the word euthanasia, is important for families as well as for the patient. The challenge of hospice is ongoing. I left the academy meetings up in Vancouver to fly back for this conference, and I must tell you that when we started as the Academy of Hospice Physicians back in the late 80s, there were about 50 of us. We wore Birkenstocks, blue jeans, and polo shirts. We were zealots. We existed outside of healthcare. Just like Saunders' model, where there is a palliative care hospice hospital and an acute care hospital, the two were not communicating. Now the Academy of Hospice Physicians is over 1,500 members. And what we are seeing is that in order to exist, in order to really provide access to care, we need to change our current healthcare model. This is a depiction of our current healthcare model. The last slide, let's say Steve receiving the diagnosis of a life-threatening or terminal illness. The initial focus of our healthcare system is on cure. That's where the reimbursement is. That's where the focus is when you walk into a hospital. Unfortunately, even at the time of diagnosis, 50% of cancer patients will go on to die of their disease. What determines how long they will live is something called performance status, not the pathology of their illness, not how far it's spread, but what's called performance status, how well they do. Do they get up every day and get dressed? Do they go out, etc.? And if you can promote good performance status, a patient may actually live longer. Unfortunately, the attention to symptom control doesn't begin right away. So in this healthcare model, Steve pursues different curative interventions, maybe even experimental therapy, and unfortunately reaches what I call the great abyss, where, God forbid, a doctor has a conversation with him to say, I have nothing left to offer you. Steve may leave the medical system, may go to Mexico and do funky things with coffee, or pursue other types of therapies. He or another family member may stumble through the doors of a local hospice where they say, I have a lot left to offer you. Good symptom control, focus on quality of life, support for you, your caregivers, your extended family. So the intensity of care increases to the point where Steve dies in a hospice setting. Those of us in palliative medicine are seeking this type of continuum in our healthcare system in the US. At the time of diagnosis, again, there can be an emphasis on cure because many will be cured. But at the time of diagnosis, there will also be an emphasis on quality, on symptom control, on support of patients and families. Throughout the course of treatment, as curative therapies may dwindle, as the options of care may change, the emphasis on symptom control may increase. And then the conversation that's held at this juncture is not, I have nothing left to offer you, but rather, what you're doing now is not benefiting your quality of life. The risk-benefit ratio is such that what the treatments that we're providing are causing more risk than benefit. And we need to change our emphasis of care to be symptom control and quality of life. And then very easily a patient can move into hospice where the domain is complete symptom control. Hospice medicine is a very restoring work for physicians because it returns the art of medicine. It returns the soul of medicine. As the biomedical model of disease developed, it fragmented the individual. Hospice is a restoration of the whole person and an emphasis on whole person care. It also restores the art of compassion, that you can ease the suffering, that you can free individuals from symptoms so that they may come to terms with the life experience and with their own death. Thank you. Are there any questions?
One of the things right toward the end there that clicked off in my mind is how often, even among evangelicals, we've kind of bought into this idea of switching the switch from cure to care. And someone as luminary as Paul Ramsey even contributed to this, what I consider misconception, in his book, Patient is Person, back in 1970, when in his introduction, he talked about the need to be able to have all of your tool bag instruments being used to their full extent and being ready to kind of switch the railroad tracks to that other track, which is care, although he certainly would be the last to deny the need for care at any stage. How do you propose to address that, what I call misconception, even among good, solid evangelical authors in the area of care for patients?
What we hope to do in terms of the medical community is through the advancement of palliative medicine. And palliative medicine is by no means going to be another subspecialty. We don't need one. But we hope that it will be a certification in an area of study, that the primary care physician, who is receiving more and more attention right now through our current healthcare system, will become skilled in symptom control and will hopefully be introduced to some of these techniques and art forms early. Because there is more and more of an emphasis on patient advance directives, the primary care physician would hopefully facilitate those conversations that allow a patient to direct their health care, to direct what their goals are. And then the physician can say, I have a lot to offer you in terms of making that transition through your life easy. A doctor never has nothing left, so to speak. You always have something to offer the patient. And sometimes that might just be the companionship, but more often than not, it's art and science to control the symptoms of progressive disease.
Wonderful presentation, Dr. Twaddle. And you touched on some reasons why I am a student here at Trinity. My question is, given the different physiological aspect of chronic pain, what can physicians and clergy do to educate patients to deal with that chronic pain, and what can the churches do?
Good question. We are just beginning to really understand pain, despite all the energies and science that have gone forward. I think in many ways we're remedial, and unfortunately a lot that we have learned has been incorrect. When I started in the area of hospice medicine, I found I had to relearn things correctly. I would say the number one struggle especially within the Judeo-Christian tradition, is the fear of taking medication for pain. Many people think it's better to suffer, that I will be great if I suffer and put up a stiff lip and go through this. What they don't understand is that by relieving these symptoms, they may have more energy to focus on greater things, to work with their family, to find closure. Now, certainly those with chronic debilitating illness, the treatment of pain is not just a medication. The treatment of pain is, truthfully, a team approach, and in non-malignant pain sources may involve more physical medicine than pharmaceutical medicine. We set goals of doing things, not stopping when the pain occurs, but rather working through the pain, recognizing that it's there. We work with the mind to help folks image or pull away from their source of pain. But I think if we could give our friends and neighbors permission when medicines are prescribed to take them and not fear that they'll be addicted. Nancy Reagan's Just Say No campaign has been insidious. We had a 6-year-old in our hospice with a brain tumor who was overheard on the phone. They told me to take morphine for my pain, and I just said no. So as community groups, if we find that our folks are taking strong opioids, we must not add the pain of judgment to that.
I was just wondering, you mentioned that often physicians who have been involved with a patient for a long time, when they have a chronic illness, you mentioned something about them becoming part of the hospice team, and I was just wondering, are physicians willing to do that, and how are they compensated? I mean, are there financial compensations for that?
That's a very good question. Unfortunately, in our current healthcare system, it's very difficult, if not financially negative impact, to make house calls, et cetera. But there are a lot of docs that do. If they can't physically go visit their patients, which I've seen most of my colleagues do, we certainly will keep them informed via fax and phone call so that they can be a part of the process. And as long as the patient is mobile, hospice might go so far as to get them to their doctor. I know that though it's a little bit undercover, my dad will drive hospice patients to their physician's office, and that can be a part of what's important to that patient. There is poor reimbursement in hospice, very poor, for doctors and for the program. Medicare recently cut its reimbursement for hospice care, and about 3 weeks ago, the state of Illinois cut Medicaid reimbursement for home care completely. And that encompasses almost all of our AIDS patients. So we rely a great deal on community organizations. Being a not-for-profit organization, that's what I work for, we can rely on the generosity of folks who have gone before, families and foundation monies. But we definitely need to change our healthcare system.
C. Everett Koop, in his book on abortion and euthanasia that was printed about 15 years ago, said in there that no one ever told him in medical school what the goals of medicine were. I find that very interesting. It's a huge gap in the literature on evangelical ethics, because if you'll search the books out here, I doubt very seriously that you'll find any book that tries to deal with the goals of medicine. I went through that analysis several years ago, and I came to the conclusion that the goal of medicine should be the relief of suffering. And if you think about that, that includes cure, that includes hospice, that includes rehabilitation that we heard in the speaker earlier. It all comes under that. And what we've done is developed in medicine is the assumed goal is to cure. Once cure is gone, like you pointed out in your first diagram, medicine gets out of the picture, when it should be just the opposite, that the caring dimension is the central part of it. And so I think sometimes we put the cart before the horse, and we need to go back to basics and among ourselves redefine what is or what are the goals of medicine.
Yeah, it's beautifully said. If you think back when there were no options for cure, I remember doing part of my medical school training with a doc who had graduated with a degree in syphilology because he graduated before penicillin was discovered. So when penicillin was discovered, his entire career changed and he became a dermatologist. But if you think back at what the physician used to do with their little black bag, going to the home, and at best having Brompton's cocktail or some elixir of morphine there, they were there to view the whole person in their family and to ease suffering. Again, when we began to think of patients as disease manifestations and start to talk about, oh, that lady with osteosarcoma, and fragment the individual. Our medical system did too. We now have super subspecialists. One takes care of the right kidney, one takes care of the left kidney, one takes care of the neurology, one the gastroenterology, and heaven forbid that they even talk to each other. We joke about multi-disciplinary care, which is basically the chart, a listing of all the different specialists who have seen them, but it's not interdisciplinary care. So again, I believe hospice is a return of whole person care. It is extremely expensive to do, if you think about it, in some realms, because it means talking to each other, and that's a lot more commitment of time. But it is also more cost effective because patient choice and control, the patient makes decisions about end-of-life care with much more education and support, and they're not motivated by a fear of abandonment.
Hi, I'm a parish nurse who has believed in the concept of hospice ever since I first heard about it in the 70s. I have recently been disturbed by some of the changes, one of which you mentioned, the cessation of Medicaid reimbursement for in-home, in other words, only in the nursing home. As a parish nurse, we were just recently contacted by the new hospice in town, which came in, and there's some competition going on. But at any rate, we were contacted at the church that they had taken one of our patients into their hospice, who is in a nursing home, who has ALS, and that they would be providing additional spiritual support and so forth and so forth. I contacted the lady who was just getting her office set up and asked for an appointment. We talked about what they were offering, and all of a sudden it seemed to be a business rather than a loving, compassionate service to the dying and their families in their home to support their wishes. Now, it may still be some of those things, but I began to pin her down as to what services, you know, I said, you have made quite a point of being Medicare reimbursable and Medicaid reimbursable. But, you know, I said, what about people who are not yet of that age? Well, she said, most people have insurance and some of that pays for hospice. I said, how much do you charge if there is no insurance? She evaded that question altogether. And I left, you know, who said either today or last night, you know, go be warmed and fed? I left and I was cold and hungry. And I was concerned because I had planned to recommend either hospice to parishioners who might need that service. And I might need that one day for myself or a loved one. Is the emphasis changing? Is this just one isolated case? What is happening?
Certainly Chicago is a hotbed of hospice competition. Sadly, again, in 1974, when Connecticut opened its first hospice, initially hospice was very much a grassroots, community-based, not-for-profit organization. Doctors weren't even involved. Fortunately, we got them involved because we need to teach them some of the art and science of hospice medicine. Well, there's always going to be somebody out there who looks at a system and says, now how can I make a buck? And I must say, this is my personal prejudice, that for-profit hospices have sprung up all over the place. Probably the largest one is something called Vitas, which is centered out of Florida. There's also Hospice of the Great Lakes, which is a local for-profit organization. These do have within their charters to accept patients who do not have an ability to pay, but they don't necessarily take all comers. They are certainly in the mode of making profit. Unfortunately, that may mean looking and cutting back on certain forms of service. As a community-based, not-for-profit hospice, Hospice of the North Shore is committed to what we call Ben & Jerry's hospice. You can practice vanilla or you can have Ben & Jerry's. We want that person to have as much quality as they can regardless of their ability to pay. But unfortunately, for-profit hospices have made the marketplace so competitive and have taken a lot of the paying patients that community hospices are threatened. So the other thing that we have identified within our Academy of Hospice Physicians is there is no standardization of hospices. One hospice may be very, very good at symptom relief, may be very up to date as far as providing palliative medicine, and the next door hospice may simply have a support group or bereavement follow-up, and there's no way of knowing when the shingle says hospice what you're going to find inside. So there is a movement afoot to standardize more than just what Medicare says you have to have, but in terms of standard of care.
In the context of Oregon, we have a new notion called comfort care along with palliative care, and comfort care is a euphemism for assisted suicide. Benton County, that's via Gene Thorne of the state, Benton County, where I live, hospice says that they will provide comfort care. My question to you is, will hospice introduce assisted suicide as part of their regime, or will there be a split and have another type of hospice?
The Academy of Hospice Physicians' current statement says that they do not support physician-assisted suicide, that they believe that the support of life and living until you die by the natural process is what they will promote. Certainly within hospices, there are those who believe in physician-assisted suicide and think that it is more merciful. But at this point, the Academy's standing is life and support of life through the process, and not to abbreviate that with a sudden controlled decision.
Thank you for a very excellent lecture. I'd just like to ask a question about the technical aspects of palliative care and pain relief. How often do anesthesiologists get involved in that and pain clinics? Because they have things like epidural catheters and regional nerve blocks and so forth that can be quite useful and leave the patient mentally unimpaired.
95% of pain, believe it or not, can be controlled via oral medication and keep the patient ambulatory and functional and very cognitively with it, so to speak. But anesthesiologists are a part of the palliative care team because there are certain pain processes, particularly those that involve nerves, that may be more benefited by early instrumentation. Certainly what you try to do is to have a primary care physician doing the initial triage and determining what the pain management scenario will be, and then accessing their colleagues who are more specialized when things are appropriate. Unfortunately, in hospice, because many times the length of life is so abbreviated, doing procedures, we won't see benefit before the person dies. Unfortunately, the #1 complaint of hospice patients and families is, why didn't I know about you sooner? The average length of stay when you ask a physician to prognosticate 6 months is less than 30 days. So in order to put in an epidural and make it maybe cost effective over the long haul may not be the thing that you choose. You do other things because they're quicker, faster, and less expensive, and maybe not the most ideal. So I guess my comment has some challenges. One, to docs in the arena to rethink your prognostication abilities, to really think in terms of a year, because then your patient will have at least 4 months. And also to think big picture, what form of pain management would best help them, not to hold out too long for the anesthesiologist, but not necessarily to put a catheter in every possible orifice right away, because you may limit a person's independence.
My question is related to provision of nutrition and hydration. One of the concerns that we've experienced, at least some contacts with our organization in Michigan, is that patients who might not necessarily even be terminal, or they're in some kind of a gray zone of diagnosis or prognosis, they're getting into hospice programs which are willing to basically not provide nutrition and hydration because it's, quote, an invasive medical treatment or whatever they want to call it. and you've got the patient dying essentially in 10 to 14 days because they dehydrate and starve to death, and it isn't really the underlying condition that kills them, and yet this is going on in hospice programs. I'm wondering if there's any standards, any line of thinking among hospice programs nationally or internationally as to what the standards should be and how do we go about this, because clearly part of the dying process is a lack of appetite. There's just no interest, or the body is going to shut down, isn't going to assimilate. But at what point are some hospices now beginning to make sure that the patient dies, perhaps hastening death, which is supposedly outside of the hospice philosophy, by just not providing nutrition or hydration so that they die of that instead of the disease?
Okay. What we have been trying to do is to standardize admission guidelines to a degree. Saunders' original hospice concept really was focused on cancer, and believe it or not, she still feels that hospice should be limited to cancer patients. There's obviously been some discussion, especially in the American camp, that hospice should be available to anyone who has a terminal illness, regardless of whether it's malignant or not. It's a challenge within the world of the non-malignant diseases to prognosticate, to establish guidelines, particularly when you're faced with things like Alzheimer's or ALS. So we are gathering our inputs from the 1,500 docs who now man the Academy of Hospice Physicians to try to establish some criteria for admission so that when they enter a hospice program, they are basically in the terminal phases of their disease. Any treatment, be it nutrition, pain, radiation therapy, whatever, should be focused on risk-benefit quality of life. If by feeding someone you can provide them with quality of life, they can obtain a certain level of functional status, they can enjoy things, then it's palliative therapy. But if continuing a nutritional supplement does not maintain a functional status, and certainly if a patient has given you indication that they don't want to eat, then it's time to withdraw it. Now I'll tell you, the issue of feeding and fluids is probably the most heartfelt struggle of families, because the first thing we do for a baby is we feed them, and food and the provision of food is perceived as love and caring, and it's very hard for some individuals to stop feeding. Certainly if you do this work enough, you can identify in the body when feeding is becoming stressful. Patients who are receiving intravenous feedings like total parenteral nutrition begin to accumulate fluid because their body is no longer, as we say, anabolic. It's not growing. It's catabolic. It's destruction phase. And so to give it these calories, they won't assimilate it, and rather they will drown as they die. So we have to start proactively to talk to families about the cues to us of withdrawing some of this support and replacing the activity of feeding for a family with something else. And sometimes that's mouth care, keeping the mouth moist or washing the face, ritualistic behavior that can supplant the emphasis of feeding. Because it's rather frightening sometimes what well-meaning spouses will shove down the throats of their nearly comatose husbands because they aren't eating. So 2 points. One is we have to have criteria as to what person is hospice appropriate, whether they belong in the program. And 2, we have to identify when the treatment is appropriate. And if anything, I see these feedings and fluids held out much too long rather than abbreviated, and stressing the patients and unfortunately drowning the patients. Well, thank you very much for your attention. I really appreciate it.